Hey everyone, and welcome to this high-yield explainer. We're diving straight into chapters 10 and 11 today. This entire overview is specifically designed to get you completely prepped for your Week 7 quiz. We are going to break down all the core clinical judgments for nutrition and hydration, creating a comprehensive roadmap so you're absolutely ready to crush this material. Let's get started.
Okay, so we're kicking things off with a quote from Barack Obama. Now, I know that might seem a little grand for a nursing quiz review, but think about it. As future nurses, you are literally the front line. You're the ones who are going to spot those subtle cues and actually initiate changes in your patient's health status. When we're talking about the older adult population, your keen eye for nutritional changes can and will be the difference between a patient thriving or completely spiraling.
To put things into perspective, just look at this number, 1 in 2. That means 1 out of every 2 hospitalized older adults is malnourished, and 50% of them are actually discharged in a malnourished state. I mean, that's wild, right? This isn't just some minor dietary issue. It's a massive systemic problem, and honestly, it's going to be your job to catch it.
Here is our game plan for today. To make sure you retain all this for your quiz, we've broken the explainer down into 6 high-yield clinical areas: physiology of aging, nutritional risks, assessment tools, nursing interventions, managing dysphagia, and hydration and oral health.
All right, Section 1, Physiology of Aging, focusing on the pathophysiological changes affecting nutrition. So what exactly is happening under the hood as our patients age? It's basically a systemic slowdown of the entire GI tract from top to bottom. Up top, you've got a decreased taste for salty and sweet foods, plus reduced saliva causing dry mouth, which we call xerostomia. Moving down, the esophageal sphincters get weaker, so reflux, and gastric emptying is delayed. Even further down, the intestinal villi actually become broader and shorter. And why does that matter? Because it directly impairs nutrient absorption. So your patients might be eating, but their bodies just aren't processing the food the way they used to.
Moving right along to Section 2, nutritional risks, from malnutrition to obesity.
For your exam, you absolutely need to know the difference between these two extremes. On one side, we have obesity, or overnutrition. This is rapidly increasing in older adults, and it complicates a ton of chronic issues. It requires very careful, specialized weight loss recommendations so we don't accidentally cause frailty. On the flip side is malnutrition, or undernutrition. And guys, this isn't just being thin, it is a heavily recognized geriatric syndrome that's rising across all healthcare settings. It drastically increases morbidity, mortality, and the rate of hospitalizations.
You know, malnutrition doesn't just happen out of nowhere. It usually follows one of 2 main paths. Either there's an insufficient intake of nutrients, or there's inflammation-related malnutrition caused by a chronic disease. But here's the thing, it's rarely just physiological. These issues are so often made worse by social isolation, lifelong eating habits, socioeconomic deprivation, simply not having transportation to a grocery store, and of course, polypharmacy and cognitive impairments. You really have to look at the whole patient, not just their stomach.
Section 3, assessment tools. How we identify cues to promote nutritional health.
Okay, so how do we actually catch this in practice? First up is the Nutrition Screening Initiative Checklist. What's really fantastic about this tool is that it looks at key lifestyle indicators to generate a nutritional risk score. It asks the practical, everyday questions. Are they eating alone? Do they lack money for food? Are they taking 3 or more distinct medications every single day? This checklist is huge because it helps you uncover those social determinants of health that are literally silently starving your patients. Next, we have the Mini Nutritional Assessment, or the MNASF. Now, listen closely because this is highly testable for your quiz. The MNA functions as both a quick screening tool and a detailed assessment. But, and this is a big but, it is absolutely only valid for older adults aged 65 years and above. If you see a multiple choice question trying to use this on a 50-year-old, you know right away it's a distractor. Cross it out.
All right, time for a little active recall. Let's test your clinical judgment. Imagine this exact clinical scenario. You're working with a widowed older patient who lives with his son. What is your very first action? Well, before you recommend liquid nutritional supplements and before you call the social worker to get them on food stamps, your first nursing action must always be to assess the environment. You have to determine who is actually shopping and preparing the meals. Think about it. You can't fix a diet if you don't even know who is buying the groceries.
Section 4, Nursing Interventions, looking at actions to actually promote nutritional intake.
Okay, we've assessed them. Now what? Moving into implementation, our main goal is to boost their food intake and manage their eating environment. Instead of overwhelming an older adult with 3 massive, heavy plates of food, a major intervention to combat that early fullness and delayed gastric emptying we talked about is to offer 5 small meals per day. And just as importantly, you have to make sure they stay sitting upright for 20 to 30 minutes after they eat to prevent reflux and aid digestion. Small, frequent, and upright. That is going to be your mantra.
Section 5. Managing dysphagia. We're talking safe practices for swallowing difficulties.
This next part is huge, and you will undoubtedly be quizzed on it. Dysphagia, or difficulty swallowing, carries a massive, life-threatening risk for aspiration pneumonia. So, testing your clinical judgment again with a classic exam scenario. For a post-stroke patient with dysphagia, what is the single most important intervention when you are feeding them? It's not just making sure the food is pureed. The most important action is having the patient swallow twice between each mouthful to clear any residual food. This directly prevents silent aspiration.
Seriously, memorize this exact step-by-step protocol for feeding these patients. 1. Sit them straight up at a strict 90 degrees. 2. Supervise all meals and have that suction ready. 3. Alternate bites of food with fluid. 4. Prompt that double swallow we just talked about. And 5. Keep them upright for 30 to 60 minutes post-meal. Also, a quick pro tip, always visually check their mouth to make sure they aren't pocketing food in their cheeks and provide a really good oral care every 4 hours.
If you take nothing else away from this section, remember these 2 non-negotiable physical setup rules for a patient with dysphagia. First, a strict high Fowler's 90-degree sitting angle. Second, wall suction immediately accessible and ready to go at all times. If you don't have both of these things completely dialed in, you do not start feeding, period. And our final stretch, Section 6, Hydration and Oral Health, focusing on fluid balance and maintaining oral integrity.
For this final section covering Chapter 11, here's a highly testable yet kind of surprising problem. While functionally independent older adults usually meet their daily water needs, a huge number of them actually drink less than 1 liter of fluid per day. Why is that? Well, it's often because they naturally have a decreased perception of thirst as they age, and you couple that with the side effects of complex medication regimens. They simply don't feel thirsty, even when their bodies are practically begging for water.
Catching dehydration in older adults is super tricky because they just don't have the same physical reserves to buffer fluid shifts as younger patients do. You have to aggressively watch for distinct signs. Yes, you are obviously going to look for dark urine and sunken eyes, but pay special attention to orthostatic hypotension, which is when their blood pressure drops when they stand up, and a really classic visual cue, longitudinal furrows. Those are deep, lengthwise grooves right down the middle of the tongue. And that furrowed tongue directly ties into our final clinical concept, xerostomia, or severe dry mouth. This is heavily linked to taking 4 or more medications. Now, this isn't just annoying or slightly uncomfortable, it severely impacts their ability to chew, it skyrockets their dysphagia risk, and it totally ruins their oral health. To manage it, we have to practice meticulous oral hygiene. And, very importantly, we need to utilize saliva substitutes and salivary stimulants to give them some relief and lower their risk of disease.
Okay, as we wrap up this explainer, I want to leave you with one final, absolutely critical thought. And it relates to the final step of the nursing process, evaluation. When you walk onto the clinical floor tomorrow, how are you going to actually prove your interventions worked? Are you checking daily weights? Are you monitoring strict intake and output? Reassessing their swallow reflex? Think about the specific, measurable data you need to ensure your older adult patients are safe, nourished, and truly thriving. Study hard, good luck on that Week 7 quiz, and keep your eyes peeled for those critical clinical cues.